first, welcome. We have smashed attendance records today. And to those of you who are new, thanks for joining us. Welcome. We do these every month. We'll put an asterisk next to that because we're not going to do one next month, as I'll explain in a second. But we do these every month. They're free. And you will get a link to a copy of this after it's posted. It's probably early next week, Monday or Tuesday, you'll get a link. And you can watch it again, why you'd want to, I don't know, or forward it to anyone else who you think would enjoy seeing this. All right, announcements. Normally, this is a special day, so you allowed me to repent yesterday. Normally, these are the second Wednesday of every month. Next month, we are taking the month off. I could say that it's to celebrate the 10th anniversary of our webinars, because we've been doing these for 10 years. But in fact, it's because I think next month it's going to be really busy. We're going to have the fee schedule come out, MIPS, the Medicare Incentive Payment System, episode bundled payments, and a whole bunch of other things will all be coming out. And with all of those coming out, I think that in December, on December 14th, we're going to do a 2-hour webinar covering whatever comes out there. January's webinar is likely to be on HIPAA, and then the February webinar is likely to be immigration issues. Okay, last announcement is, remember, you can ask questions by typing them in the chat box, but you have to move your mouse to do that. So, with that all out of the way, let's dive in. We've got a lot of material to cover today. In fact, I wouldn't be surprised if we run a couple of minutes over the hour. Obviously, if you have to sign off, you sign off, and you can always see the tail end at the link if you want. Here's kind of the list of what we're going to talk about, a little bit on each of these. If you think about it, there is no way in an hour you could cover everything about health law. But to start off, I will say some things in here that may vary from things you've heard before, and there's always a question of who do you believe. And I had a great example of that with a client this week. We were talking about billing for shared visits. And actually, that's going to be my Monitor Monday segment next Monday, so I'll keep it short here. But basically, when you have a dispute with someone, make them share the rule with you, so you know what they think the rule is, and you can compare your take with theirs. Good lawyers can disagree. Often, however, it's because one of us lacks information, right? If you've got two good lawyers and all have the same information, more often than not, they should come to the same conclusion. They won't always. And your job then is to figure out who to believe based on making each side make its arguments, and then you act as the juror and decide who is more credible. Whose ox will be next gored? And that's a really interesting question, and I don't fully know, but I think bundled payments that are coming and will be the topic, like I said, one of the topics in December, are going to be a big deal. I didn't expect capitation to take off back in the 80s. I don't think people want to go to doctors who are paid more to treat them less. Bundled payments feels different to me, and so I think this one might stick. An interesting question within the health world is stuff gets labeled as fraud all the time, and I would say incorrectly. Personally, I think that there's a political agenda to a lot of that fraud, right? I think that when we don't want to talk about rationing healthcare, for example. It's kind of scary. It's politically fraught for the people who do it. If you talk about decreasing the amount of care provided, that freaks people out. Remember the whole death panels conversation. But if you label conduct as fraud, that you can criticize. And I think that creates a strong incentive to characterize behavior that you or I might think of as close to the line as being fraudulent. And I think we have a duty to try to stomp that out because I think it has policy implications. Last point, I'm going to be talking primarily about federal law, but state law matters. It matters a lot. And one of the reasons I want to mention this, we've got people on today literally from Florida to Alaska and Hawaii to Maine. So we've got the whole country covered. So we can't cover all of the relevant state laws for you in this call. And I sometimes hear people say, oh, well, we have to hire a lawyer in our state because you need to know state law. And it is true you need to know state law, but I want to tell two quick stories because I don't think it is necessarily important to hire a lawyer from your state. So the first story was a case where I was working with a client in Texas, and the issue involved economic credentialing at a hospital. And I was digging around and found a law in Texas that basically forbid what was going on and made it won the case for our clients. All right, so it was a situation, there were multiple lawyers from Texas and none of them knew about that statute. And I, a Minnesota lawyer, came in, did some research and found this law and prevailed for my client, which can make me sound like a hero, but I will sound like less of one after this second story, which is in Minnesota, I was working for someone, and there was a lawyer who was from out of state working on a project, and she found a provision that I had never heard of in Minnesota law and schooled me. And the lesson from these two episodes is that the goal isn't to hire a geographically proximate lawyer, it's to hire a competent one, because a competent one will dig through and find out what's going on. And in fact, there's an irony. Sometimes when you're operating in an area of the law that you know well, you skip the step of looking to make sure that there isn't something there. And in fact, I mean, that's not always crazy because it's expensive to go look at times. But sometimes someone who's new to the situation is better. So don't be afraid to hire the best lawyer you can, even if they happen to be half a continent away. All right. As part of our Health Law 101, we want to talk a little about conceptualizing the law. And I think it's good to realize most healthcare laws fall into sort of buckets, right? Some of them govern relationships. Some of them talk about how you can bill. It's very easy to make a mistake. I make this mistake all of the time, which is framing as saying you can or can't do something. You know, can a nurse practitioner bill for this service when he or she sees the patient alone? Often, when I'm saying, can you do it, what I really mean is, does Medicare cover it, right? And can we bill for it is a different question. And it's different in multiple ways. One of them is there's often payer variability. You may have something that Medicare prohibits, but Medicaid allows, and a private payer requires, and that's possible. And so always be careful to differentiate between what is illegal and what you can't bill for, because you may be able to do something for free even if you can't bill for it. And as for payer variability, people often think discrimination is illegal. Discrimination is only illegal when you do it on an illegal basis. You can discriminate for all kinds of good reasons, and different payer rules are a reason you may have to discriminate. People often would like to have a consistent policy. You know, we'll treat all patients the same. It's certainly administratively easier. But I've seen situations where an insurer will say, we will cover physical exams, preventive services, and if more than half of the visit is preventive, you just bill the whole thing as preventive. Whereas Medicare would say, you've got a split bill between what's preventive and what's the sick visit. You cannot comply with both of those with one consistent policy. So sometimes you're going to have to discriminate. The legal hierarchy is important. And it's, you know, at the top of the legal hierarchy is always the Constitution. Then we've got statutes. Below that, regulations. Then we get the manuals, and then we get guidance. In the fight I was having about shared billing this week, I was looking at manual language. Someone else was looking at a newsletter. And manual language is going to trump newsletter. And it's always important to think about where what you're looking at fits in the hierarchy. A statement from someone who works for the government is technically not really that binding at all. It's at best below these other various things. You know, someone who works for the government can't contradict something that's in a regulation. Just a little aside, not all laws are criminal. You know, we're going to talk about Stark, it's a civil law. And man, in this healthcare context, some laws are totally counterintuitive. So now I'm going to just go through some of the laws that govern life in the healthcare world. First one is antitrust, which we start off with the Spice Girls. Antitrust can be summed up as tell me what you want, what you really, really want. And we don't know the answer to this in the health policy world, right? On the one hand, integration is clearly happening right now. And I think people think that we want integration and consolidation because we want to avoid redundancy. People will talk about having multiple MRI machines on a corner and say that's a bad thing, right? That's kind of where certificate of need comes from as a concept. Now, let's compare that to the principle of competition. Who would say that having 3 gas stations on a corner is bad? I've never heard anyone say that, right? I mean, I guess I take that back. In my neighborhood, we tend to have 3 of everything. We'll have 3 eyeglass shops, and you sometimes say, boy, it would be nice if we had an ice cream shop, which we used to have 3 of, and then all 3 closed. So you might say, boy, I want variety in terms of the gas station, but from a competition standpoint, everyone would say 3 is good. In healthcare, we would sometimes say 3 is bad. And there is one logical thing going on there, which is in healthcare there's a concept called supplier-induced demand, which is the idea that physicians and other medical professionals can drive consumption in a way that consumers can't completely control. And so that if you have more supply, the existence of the supply will by itself up a demand, something that you generally don't have in non-professional industries. You could say the same thing about lawyers and car mechanics and all that other stuff too, right? But the American system is founded on the idea that competition is a good thing, and we do not know in healthcare what we want. So analyzing antitrust in the healthcare context is tough because things are often going on. I will note this. People are often scared of mergers because they're afraid of getting too big and creating a monopoly. But in the monopoly analysis, one of the key questions is barriers to entry. And in the physician world, barriers to entry are small. So if you're a physician group and you're worried about getting too big, I would be less worried most likely than you are right now. If you're a hospital, very different analysis because the barriers to entry are very high. All right, next thing we're going to talk about is the False Claims Act, commonly abbreviated the FCA. So I'll do this pretty quickly because I think a lot of people know it, but this is Healthcare 101, so we're going to cover some basic stuff, and for those who are more experienced, I apologize, but hey, that's what our title was. So the False Claims Act came out of the Civil War era, and it was re-upped in the 80s with fairly significant penalties of $5,500 to $11,000 per claim. New rules just doubled those, basically. So they're now gigantic. All right, you can get up to $21,500 penalty per claim. In addition, most states have the law, and so if you violate the False Claims Act, they can do treble damages and then this per claim penalty. Now, the law has some type of materiality provision. So is every mistake a false claim? The answer is no. We'll talk about that in a second. What about dating errors? I wish I knew more about dating errors, but in order to know about dating errors, you have to have had dates, and in high school that just wasn't so much my thing. But let's say you've got a dating error. Is that a false claim? And I would say absolutely not. It's a mistake. Now, if you have 100 of them from one person, you get a little more worried. You could then be so reckless. The False Claims Act allows penalties for reckless disregard of the truth of a claim. But there's this quote from then Deputy, later actual Attorney General Eric Holder, where he basically said, actual knowledge or deliberate ignorance or reckless disregard of the truth are what give rise to false claims. Let me make this very clear. The False Claims Act does not address, and we should never use it to pursue, honest billing mistakes or mere inadvertence. I would say I wished that that were in fact the case. I think my colleagues and I would say uniformly we've seen cases that we think are mistakes being pursued as false claims. But this quote becomes a useful thing to fight back against that. So the law allows someone to sue on behalf of the government, and then they reap between 50 and 30% of whatever the government recovers plus attorney's fees. One question people ask is, hey, can we ask our employees to promise not to file one of these? And I think Gary Larson, my favorite cartoonist, captures that very well here. Well, yes, that is the downside, Fluffy. When we kill her, the pampering will end. If you bring a False Claims Act case against your employer, that may be the end of the employer. And I skipped ahead a little bit here. I skipped a slide ahead. But basically, these things are generally filed by a disgruntled employee or a competitor. They're filed under seal. You may not know about it for 2 or 3 years, okay? And so here's my question that I was just trying to answer, which is, can you ask your employees not to file a Qui Tam suit? And once again, Gary Larson captures that really well in one of my favorite Gary Larson cartoons. Notice you must be as tall as this sign to attack this city. That sign might scare off a monster, but not a smart one. And similarly, I don't think a waiver is likely to be enforceable. The few cases that are out there have generally said not. What you can ask the employee to do is to forfeit any financial recovery under the False Claims Act. So you can say you can still go to the government and bring it to their attention, but you can't get rich off of it. That type of waiver probably is enforceable. And I would most commonly do that as part of a settlement agreement when an employee is leaving. In fact, I encourage people to have that language in any severance agreement. I don't like the idea of going to every employee and making them promise not to bring a False Claims Act case because it makes it sound like you think you're committing fraud. So I'm not personally a fan of that, in addition to having concerns about its enforceability. I am a fan of asking all employees regularly to certify whether they have any concerns under the False Claims Act. And we have a little certification form that we'll send you for free if you want. If you've never seen it, you can send me an email, throw certification in the subject line, and I'll send you a copy of our form. Like I said, it's free. When you send that form out, you then need to make sure everyone fills the thing out, or when everyone fills it out, you need to make sure you dig into all of the concerns they raise, because they will raise a lot of them. A lot of them will be HR-oriented things that have nothing to do with compliance, and you got to separate the wheat from the chaff and deal with the wheat. There's often a tension between secrecy and openness, and I fall into the openness camp. Remember, reasonable people can differ on some of this stuff, right? This is a judgment call. I am a fan of letting people know what's going on and making people feel like they're part of the team. We have a whole webinar on compliance plans. It's available for free. I forgot to look up which month it is. It should be easy to find if you go to our website. We'll have a link to the past webinars, and you can scroll down, or if you shoot me an email, I'll just send you a link. Now, in the old days, there was a distinction between what were called conditions of payment and conditions of participation. Conditions of payment, as the name suggests, is what it takes to get paid, and a condition of participation, if you breach that, then they can throw you out of the Medicare program. But most cases were saying that if you made a mistake in the conditions of payment, that didn't give rise to a false claim. Medicare could throw you out of the program, but they couldn't take your money. A Supreme Court case this summer, the Escobar case, changed the focus a bit, and many people described it as making it easier to file a False Claims Act case. I actually don't think I would put it quite the same way. I actually think that this case isn't that bad, but what it did was it said, the test is materiality. Is the information on the claim important enough that the government would make a payment decision based on it? If yes, then you can have a False Claims Act case. If no, then you can't. And actually, I failed to include in here, but there was a really good paragraph in there about how if you were asked to certify compliance with every law in the United States, which is basically what you do when you fill out an 855 form, that would mean that something like speeding could give rise to a False Claims Act case, and that's just silly, is what the Supreme Court is saying. And I would agree, but you see False Claims Act cases based on violations of trivial laws, and I think what the Supreme Court is saying is it's got to be a real law that matters, that someone cares about. All right, let's talk about now some of those real laws. The first one, the Medicare Antikickback Statute. So that makes it a felony if you offer, ask for, give, or accept any payment that's intended to influence referrals under the healthcare program. This is actually one of the health laws that's pretty easy to explain. And the government uses a one-purpose test that says even if there's a legitimate reason for what you're doing, if one of the reasons is to influence referrals, it's a felony. This means intent is everything. There's really only one important question, which is why? Why are you doing the payment? And if there are 10 reasons for it, but one of them is when we give them this, they'll want to refer to us, you should be worried. Now, that means, like, let's say free lunches come up a lot, right? Like a drug rep is coming out and offering free lunches. Well, if the free lunch is to get someone to show up and hear about the drug, that is not a violation of the Anti-Kickback Statute. Now, it might be, you may not want to allow people to do it because you may say, we don't want people's judgment being influenced by gifts. And that's completely kosher, right? I'm not talking about ethics here or what you should do. I'm talking about the Anti-Kickback Statute. Is it a felony? And I think a drug rep can come in and have pizza if that's the incentive for people to come hear his or her pitch. And there are two reasons. First, I don't think anyone's changing their referral patterns off of pizza. I think that's relevant. And second, the point there is to get them to listen. By contrast, if they're giving them something in exchange for actually taking an act, like prescribing the drug, that's a felony. Now, there are safe harbors under the Anti-Kickback Statute. They're super narrow, and you do not need to fit in one. I can't emphasize that enough. You don't even need to get close to them. It's all about intent. The safe harbors are super duper narrow. For example, the ambulatory surgery center safe harbor includes a condition that if you're doing a joint venture between a hospital and doctors, the hospital can't be in a position to refer to the venture. And they explain that means that the ASC has to be outside the hospital's service area. Well, what hospital puts up an ASC outside the service area? And the answer is none. And the government acknowledged that no ASC is going to fit within the safe harbor, but then they said, if you fit within the safe harbor, we can't prosecute you, so we've made it narrow. So don't get stuck on these safe harbors. Instead, it's really a common sense analysis. Most of the time when we do anti-kickback analysis, it's a 15-minute phone call or a half-an-hour phone call, not a 20-hour research project. I will close by noting I have been involved in a very complicated research project lately on anti-kickback statute, an exception to what I just said, where I am taking a different approach than two other very large nationally known law firms. In an opinion, one of those law firms just said, "We did not find an advisory opinion on point which suggests this is illegal." And I read that and I was stunned, because here was a very reputable law firm basically saying silence suggests illegality. And I mention that to highlight lawyers can approach things differently. I said at the beginning that with the same information, you'd think smart lawyers would come to the same conclusion. I guess that is not always true. And I don't understand what's going on this one. If the fact that there's no advisory opinion means that there is no information about whether it's legal or not. You shouldn't be drawing a negative inference. But this other law firm is choosing to draw the negative inference. And as a consumer of legal services, I think you have to push all of us to figure out what our biases are. So what are things that get you in trouble under the anti-kickback statute? Well, let's say that a doctor is going to be a medical director at a hospital, and the hospital doesn't expect him or her to do any work. One of the first criminal cases was in Kansas, and that's exactly what it was. A geriatric physician was getting paid $60,000 a year, and when asked to describe what work he was doing, the doctor couldn't come up with anything, the hospital couldn't come up with anything, and that became a felony case. And that's not, they came up with a little something, but they didn't come up with $60,000 of something. A doctor, a surgeon, is frustrated with stuff. And so he goes in and says, if you don't give us what we want, we're taking our business to the other hospital. Can they do that? I'm really worried about that. Now let's change it to say, we're really frustrated with the OR turnaround time. If you don't improve the turnaround time, we're taking our cases someplace else. That feels different to me. I don't think that's asking for a payment. I think that's asking for improved, basically, quality, and I would be okay with that. I would be more worried if you said, if you don't support our athletic trainer outreach program, we're taking our cases elsewhere. So here's the advisory opinion process. We're not going to spend long on that. I am not a fan of getting them. I think it's basically a waste of time. But you can get advisory opinions if you wish. The Stark Law. Now, I could put you to sleep talking about the Stark Law. I'm going to try not to do that. It's complicated, but let me try to keep it at a big level and get some basic ideas about Stark out there. So the first thing is about Stark is it only applies to designated health services, commonly abbreviated as DHS. Now, all hospital services are designated health services. The next slide will list the others. So this means every relationship between a doctor and a hospital is basically covered by Stark as long as that doctor creates a plan of care that sends people to the hospital. All right. So if there's any value flowing between a doctor and a place from which designated health services are provided, that triggers the law. Unlike the anti-kickback law, where intent is everything, intent doesn't matter. We don't care whether you're intending to pay for referrals or receive payment for referrals. If there's an economic relationship between a doctor and someone who provides designated health services for that doctor's patients, the law applies, and you have to meet an exception. Now, you can't go to jail for violating Stark, but there's a penalty of up to $15,000 a claim, which feels like jail. Here is a list of the designated health services, so I won't read it aloud. You can just kind of look at it at your leisure. Now, some of you know I'm a storm chaser and if you look at this picture, if you look right above the rear view mirror at the ground, it's a little hard to see. There is debris on the ground. What we're looking at here is a tornado. It's not obvious. You got to squint, really, but that is an actual tornado. Stark is kind of like that. It can be hard to see at times. It's just harder to do a Stark analysis. I often will not do them on the phone when someone calls. I want to get the information, hang up, and think about it. Now, it may only be 15 minutes of thought, but I want to do 15 minutes of pure thought because Stark is scarier. Even it's weird. Anti-kickback can send you to jail and Stark can't, but Stark is just harder. Now, Stark only applies when a doctor orders services covered by Medicare or Medicaid, right? It doesn't apply to private pay stuff. And then it has to be provided by someone that has the financial relationship with the doctor. Now, one of the things that makes Stark confusing is that the financial relationship doesn't have to have anything to do with the referrals. So, and I like to use the example of lawn mowing. I'm a doctor. My daughter runs a lawn mowing business, and she provides lawn mowing services to the hospital. Because of the way Stark works, Stark applies not just to relationships with me, the doctor, but to members of my immediate family, including my daughter. So when the hospital is paying my daughter for lawn mowing, that is a financial relationship, and Stark is going to apply, even though lawn mowing clearly has nothing to do with hospital services. It's a financial relationship between the hospital and me or a member of my immediate family. Then, the word referral is weird, because you would think that referral would be if I said to a patient, go to the hospital. It's much broader. If I say to a patient, you need an x-ray, and I never mention a place that provides x-rays, wherever the patient goes, I'm deemed to have referred that patient, because referral includes creating a plan of care. Another confusing thing is that the entity that provides the designated health service isn't just whoever bills for it, but the law also says that whoever if there's someone who provides the service but doesn't bill for it, that still can be considered an entity for purposes of Stark. So like in a diagnostic test situation, if you've got someone who provides equipment and techs and leases it to the hospital, there's more than one entity. So bottom line, this is really confusing. I don't want to lull you all into sleep, but that's kind of Stark 101. For those of you who are listening from a rural area, which means that you're outside of a metropolitan statistical area, and 75% of your patients are from outside of a metropolitan statistical area, you get a lot more leeway because there's a rural exception that protects ownership in rural areas. If you're trying to figure out if you're in an MSA or not, you can look at the Census Bureau site. If you get frustrated, send one of my colleagues or me an email, and we can send you the thing. It's done on a county-by-county basis. You do have to know, just because you used to be rural, counties can become urban. Mankato, which many of you may know from Little House on the Prairie fame, was rural, and then it became urban. The rural exception only protects ownership and not compensation. So doctors can own things in rural areas, but if they're getting paid in other ways, that can be a problem. But still, things that would never work in a city can work in rural areas. Per-click payments. Generally speaking, if a doctor is referring patients to a service and the doctor is getting paid per use, that's generally going to be problematic. So like if a doctor has a scanner and they're leasing it to a hospital per scan, that's not going to work. Now, if you set the same thing up on a flat fee per month, that can work, all right? And also, if you have situations where the person who's doing the lease isn't referring. So you've got like a mobile imaging company that comes in, not owned by doctors, comes into your hospital and provides scanning services. That can be per click, and that's not a problem. Okay, in rural areas, things are going to be easier. I think I've beaten that one into the ground. Compensation formula issues. Stark looks at how you pay doctors. And it only applies to the Medicare and Medicaid revenue, although I always worry about whether clinics struggle to, whether if you were to say I'm going to pay someone for their private pay referrals, if you make a mistake, you can get into trouble for Stark. But doctors can't get paid for their referrals for designated health services. So in other words, you can't credit a doctor in the compensation formula for the labs they order, the x-rays they order. You can credit them for the work they personally perform. So they can get credit if they read an x-ray, they can get credit for that. But they can't get credit for the technical component, for the labs, other services like that. A few Stark landmines. Generally, you need to have written agreements, and so many people get tripped up by this. Employment is an exception, but almost everything else needs to be written, and every time you amend it. So classic Stark problem that's just silly. A clinic is leasing space from the hospital. They decide to add one more room. Everyone agrees that we're doing it, but but we never memorialize it in writing. The clinic even starts paying for that extra room. So the money is fine, but we don't have the amendment in writing. That's a Stark problem. So you have to remember, now, if you exchange emails, that may be enough to get you there. So at least exchange emails, but really you want to have signed agreements. And I would highly recommend all agreements that doctors enter into have auto-renewal terms so that you don't find a situation where the lease expired or the medical director relationship expired. You continue to provide services, and now you have a giant Stark problem. I'm just going to quickly kind of compare Stark and anti-kickback statute. These slides are really there for your future reference, just to compare them, right? Kickback is criminal versus Stark being civil. Anti-kickback, you can go to jail and then also have monetary penalties. Stark has slightly different monetary penalties. Anti-kickback is all intent. Stark, we don't care about intent. Anti-kickback, you don't have to meet a safe harbor. If you do, you win, but you don't have to, and you often won't. Stark, you must meet an exception. Anti-kickback only applies to relationships an entity has with other entities. It doesn't apply to any payment you make in an entity. A hospital can't violate the kickback statute paying its own people, all right? Only paying outsiders. Stark does kind of pierce that corporate veil. So let's look at a few examples. Anti-kickback is everything paid for by a federal health care program. Stark is only Medicare and Medicaid, and you can get an advisory opinion. Before we dive into the examples, also tax exemption. So if you are nonprofit, you can become tax exempt, which means you don't pay income taxes, and you're prohibited from having what's called private inurement or private benefit, which is where other people get undeserved money from you. So like if you pay too much money to a doctor, a hospital can lose its tax exempt status. So this only applies to tax exempt organizations. So the kinds of things that happen, can you have a medical director agreement? Of course. It just has to be reasonable comp for the work that's done. Can a hospital co-market with a doctor, or can a device company? Yes, but they can't. The hospital or device company can't subsidize the doctor. The doctor has to be contributing something to pay his or her own way in the joint marketing effort. If you get a grant from a device or drug company and you're a hospital or a doctor, there better be something you're doing for that money. It's got to be research related or something. If they're just giving you money, that's a problem. All right, now let's go through some examples. And first, I just want to note one of the very first situations I ever worked on was a letter from a drug company to a clinic that said, this is okay, right? And salespeople often have an incentive to say, this is okay, because they're selling things. If a salesperson tells you something is okay, check that out with your legal counsel. So first example, a drug or device company, let's make it a device company, says, hey, this off-label use of a device helps cardiac patients. They want a doctor to come give a speech about the merits of the device. Can the doctor do that? Well, off-label promotion is an area that's got a lot of activity right now, and a doctor can use a device off-label, but they cannot promote a device off-label. So getting paid to talk about off-label use is problematic. And it's a distinction between use, so doctors can use devices and drugs off-label. They can't encourage the use of drugs or devices off-label. Now let's say a device rep really wants a doctor's advice. And so they say, hey, we'll pay you $200 an hour if you'll come to a focus group in San Diego. So let's think about the different ways that this matters. So what you'd have to look at the three laws, right? Stark, anti-kickback, tax exemption, ethics, and stuff like that. So Stark, the device company is not providing designated health services, so we don't have to worry about Stark. Anti-kickback, can this doctor order stuff from the company? Yes. So now we're going to have to think about the big question under anti-kickback is why? Why are they doing this? So what are you paying the doctor for? Are you paying them for their time? Well, if it's for their time, that's probably legitimate. But I think it's reasonable to ask other questions. So we're doing this in San Diego. Could it have been done someplace else? You know, why could they have done it via teleconference? Could we have done it in some less ritzy location? Is it really, is the trip to San Diego part of the compensation to the doctor? And I don't know the answer to that here, right? It's just a question I'm going to ask. I remember about 10 or 15 years ago watching one of our local news stations sneak up on a doctor at the baggage carousel at the airport after he'd returned from a trip to San Francisco, where he'd spent half a day over the course of 4 days giving advice to a drug company, and then spent the afternoon seeing the sights at Napa, and then, of course, ironically, at I'm blanking on the name of the prison, Alcatraz, offshore. And so they went and toured Alcatraz on the dime of the drug company. And in essence, the news station is saying, you could have done this meeting in 2 days. It was really tourism, right? And those are all legitimate points to make. Now, the drug company is not a nonprofit, so we don't have to worry about tax exempt. And that's kind of how you go through these things step by step. Then, remember, I said you got to not forget state law. Remember state law. You might have a disclosure thing. Like, actually, there's the federal disclosure, the Sunshine Act, if you're dealing in the drug world. But you might have state disclosure laws that require you to tell people what's going on, state anti-kickback laws, and the like. So a drug rep offers to pay a doctor $200 an hour to listen to their explanation of why their drug is better. So if it really is just to listen, I suppose you could argue it's okay, but I think you've got a duty to learn about how drugs work, and I don't like this. I don't like doctors getting paid to hear. That sounds illegal to me. I would be very nervous about this. Another real-world example. You've got an orthopedic physician and a family practitioner who are pals. It's the family practitioner's birthday. The ortho takes the doctor out. The total bill is $350. Can the orthopod buy? And I'm not super worried about this. All right? Now, let's assume that there's some reciprocity and that the family practitioner invites the orthopod over for dinner and they do stuff. Now, let's change the facts and let's make it smaller. It's only $100. But the orthopod takes the bill and runs it through the practice as a promotional expense. That's a bad fact, right? That makes it worse, because now instead of it being friends, it's promotion. Now, I don't think this makes it a felony automatically, because there's an intent element and stuff like that, but I'm much more nervous about this scenario than I was about the other one, even though the dollar amount is smaller. Okay, this, as a 2-month-old lawyer, one of my clients got a letter from, I love this, it was the, quote, legal department that said, hey, if you offer this free, or if you prescribe this device 10 times a month, actually in my case it was a light box, a PUVA light box, we'll give it to you for free. And the legal department says this is fine because this helps patients and not you, and therefore it's not considered a kickback. Well, this is part of the famous patient care myth. The fact that something might be used for patient care is really immaterial. If it's an expense, if it's something of value to the practice, something that they otherwise would have to buy, it doesn't matter how we label it. Whether someone gives you $500 in cash, or a $500 piece of equipment, or a $500 fellowship, whatever we label it, it's $500, right? And you don't get out of kickback things because of the label you put on it. It's the value that's the issue and why. So that's what counts, not whether it helps patients or not. This is one that comes up a lot. You're buying something, let's call it devices wholesale. Maybe you're a doctor and you've got a surgery center. So you're buying these things, and the manufacturer says if you buy 10, they're $1,000 each. But if you go up to 100, there's a volume discount, and you only pay $800, and afterwards there's a $100 rebate. This, to a bunch of people, sounds illegal. And I don't think it is. I think that this is just a pricing discount, and I think the only thing that would make it illegal is if the recipient, A, pays on a cost report, is getting paid on a cost basis, which is rare, and then B, as part of that, fails to disclose the actual price. So as long as they report the discount and they get paid on a cost basis, it's still okay. This is just a volume discount and not a problem. All right, so you have to train an RN on something new that's out there, and there's a seminar in Orlando. So you contact the device company and say, we want you to fly the RN out there for us. I'm going to be kind of nervous about that, all right? Because I think you're asking a company to pay you, and that's possibly an incentive for you to use that company's product. Now, if the company were to approach a trade group and said, we'll sponsor 10 scholarships and you trade group, give them out to people who are poor, that's going to make me, I'm not going to be nearly as bothered about that because it doesn't seem like there's a linkage. We're not giving them to people who are big referral sources and the like. All right, that may be more than we wanted on anti-kickback, but I think that stuff is a big deal. The next area I'm going to talk about is entirely different. It's incident to billing. And I remember as a baby lawyer first hearing this phrase. I was confused about this for like almost 2 years, partially because the title is so confusing. So the full phrase is it's an incidental part of a physician's service. And what we really mean here is billing by services by someone other than the physician under the doctor's name. And now we've expanded that to be for non-physician practitioners. They can also, like a nurse practitioner can bill for things done kind of under their general supervision, or well, poor word choice by me, under their direct supervision. Now, for a clinic to bill for services that are incident to a physician, you got to meet like 6 tests. First, the clinic has to be paying the expense of the ancillary person. So what would be a problem there? Let's say you're a clinic and the hospital is providing you with a nurse to do rounds or something like that. First, the fact that it's in the hospital is going to be an issue, but let's put that aside. Let's say that the nurse is coming to your clinic, or let's say a device company is sending you a person to your clinic. If you don't pay for that person, you can't bill for that person's work. If the clinic is the sole provider of your medical, or the clinic has to be the sole provider of the medical direction. Now, the physician has to initiate the course of treatment. This is a key phrase. They have to initiate the course of treatment. I hear many people say that that means if there's a new problem, the doctor has to see the patient. I would disagree with that characterization because in the manuals, the language is initiate a course of treatment. And let's take chemotherapy. If I'm the oncologist and I start a chemo process and then the patient comes in a week with low blood counts because they're having some negative reaction to the chemo, that's a new problem, but it's still part of the course of treatment. And I am convinced that that follow-up visit can be with a nurse practitioner and you can bill that under the doctor's number. And I will defend that one till the cows come home. But I think many people would disagree and say that's a new problem. And I have to admit the conventional wisdom out there is new problems have to see a doctor. I just think that the conventional wisdom there is ignoring the plain language of the manuals. The service has to be something typically done in an office. That's not a problem very often, but this one is in red. The service can't be in a hospital or in a nursing home. And this is confusing. In a hospital, services that you would conventionally call incident to in the clinic are different. They're now shared visits. And in the hospital, a doctor and a non-physician practitioner, if they both see the patient, they can combine their work into one visit. As an aside, someone just sent me a Medicare newsletter, and I'm going to talk about that on Monitor Monday, so I will save that one for Monday, and you can tune into a quirk on shared visits. A clinic, the supervising physician and the person whose name is on the bill has to be in the office suite when the service is provided. So if Robert and I are both doctors, and I'm seeing a patient regularly, but I'm on lunch when the doctor comes in for their chemo treatment, and we're going to bill that under a doctor's name. I'm at lunch. Robert is here. Robert's name has to go on that bill. And you might think, but wait, David, you're the doctor. Doesn't matter. The supervising doctor's name has to be on the bill, and that has to be someone who's in the office suite. All right, fee splitting. As I often spooner, flea spitting. Fortunately, I did not today. So this is a state law, and it doesn't apply in every state, but most states have some form of fee splitting that prohibits a physician from sharing revenues with non-physicians or even physicians that aren't part of their group if you're doing it on any basis other than the work performed. And what it's often designed to do is you can't, sometimes they call them cappers and steerers. You can't have someone who stands on the corner and says, go see Dr. X, And if you go see, I'll give you a little thing. If you go see Dr. X because of me, I get $5 out of that visit. So when you've got marketing relationships and things like that on behalf of a physician, this can apply. So you have to be a little bit careful. If there's a sales representative for a doctor, you have to decide if that violates local state law. And then there are some really weird twists. Florida, if a management company has a percentage management contract, the state of Florida interprets that as fee splitting. And so where you see these practice management companies come in, we're seeing more and more of this. A couple of my colleagues are spending a lot of time on private equity stuff right now. If you're interested in that at all, Katie Douglas in my group and Steve Beck are getting it. But call Katie Douglas because she does a ton of this. It's happening a lot out there. But if you're in Florida and you're trying to set one of these deals up, the fee splitting statute can become a problem. Also kind of related to that, there's a concept in many states called the corporate practice of medicine doctrine. And this is a fear that we want professionals to exercise their judgment free of the corrupting influence of money. Some of you are probably laughing right now, right? But the idea is we don't want a company telling doctors what to do. And so most states have created the idea of professional corporations, and this says that the practice of those kinds of professions, often lawyers fit into this bucket and other professions, but doctors can't be employed by a company. It's a state law question, but it can affect situations like when you have a setup like an urgent care clinic, the minute clinics of the world, right? The company can't employ the professionals, and there's a structure that you use then often is you have the professional company, and then the management company is run by the company, and they provide management services to the doctor, but the doctor remains employed by him or herself. Okay, so it's a doctrine that's out there, something you have to pay attention to. Next thing we're going to talk about is the 2 midnight rule, and I got a bunch of slides on this. We're not going to slog through them in gory detail, and before I get into the slides, I want to just talk on the principle. So the 2 midnight rule is a change that happened in October 2013, and now I'm suddenly blanking on if it's October 2013 or October 2014. October 2013, where Medicare said, in order for a patient to be an inpatient, the test is whether a doctor expects the patient to be in the hospital over 2 midnights. If the doctor expects the patient's going to be there for 2 midnights, they're an inpatient. If they don't, they're not. Now, obviously, this can change over time, right? When you come in, maybe we don't expect you to be there for 2 midnights. We expect you to be there for 1. But the next day, suddenly it becomes clear you're going to have to stay a second night. Once it's clear you're staying a second night, you become an inpatient. And so anyone who's in the hospital for 2 midnights, really under this principle, has to be an inpatient. You cannot have observation for 3 nights under the 2 midnight rule, because once you've been in for 2 midnights, once it's 11:59 on that second night, we know you're going to be in for 2 midnights. So this actually was fixing a problem where we used to have people who were considered in observation for days. The full language of the rule is in here, and note a few things that I've got like in blue. So you need to have a physician order in the medical record, and it has to be supported by physician admission in progress notes. Those of you who have heard me speak before have probably heard me say that the concept, if it isn't written, it wasn't done, is not the law. And if you haven't heard me talk about that, it's important, and you should, and send me an email, and I can send you a link to one of our past webinars on this topic. In 2 sentences, the evaluation and management guidelines are guidelines, and failure to document a service in accordance with them doesn't create an overpayment if the work was really done. If the work was done and not documented, that's not a problem. Well, here we have a regulation requiring documentation, and that's going to make it harder to argue that if you're missing an order for admission, it will be harder to argue that the admission is valid. Not necessarily toast, but it's going to be harder because of this regulation. I've got a few things here. I'm not going to go through these in gory detail, but the order has to be someone who's got admitting privileges, who understands the patient condition, and the practitioner can't delegate that to anyone who isn't authorized by the state to admit patients. So if you've got an NP or PA, you might be able to delegate to them if they have the authorization to admit patients. But if your state doesn't let PAs or NPs admit people to the hospital, under the 2 midnight rule, you can't delegate to them. And the physician order has to be furnished before or at the time of admission, according to the rule. So there's a bunch of stuff in here to make life a little bit more difficult in the paperwork side of things. This is just the language of the rule. I'm going to leave it out there for your review. At a later point, I would say if the doctor, so if for some reason you don't wind up, let's look at this one. If you don't stay for 2 nights, so that does not screw up your admission, right? If you go in for a surgical procedure or a diagnostic test or toast, and you're expected to be in for 2 nights, you're an inpatient. You're supposed to document in the medical record the reasons for staying in. But if something comes up and the person gets out early, they die, or something like that, that does not change the fact that they were an inpatient if the expectation is they were in for 2 midnights. The other thing, and I didn't know about this until a few years ago, physicians have to sign an acknowledgement. And basically, when they get on staff, they have to have a signed acknowledgement statement on file that acknowledges that, the stuff on this slide. So hopefully every hospital on here is getting doctors to sign something like what's on this slide. Just check and make sure your hospital is. Like I said, this is an area I didn't know about until a few years ago. So I sometimes worry if other hospitals do. Okay. So this is all about physician expectation. And basically whatever the doctor expects controls. There is one exception for intensive services that are provided for less than 2 midnights can still be inpatient. The government has provided remarkably little guidance about that. I should also just mention there's a moon notice requirement that for people who are in overnight but not necessarily going to be admitted, Medicare is going to require you giving them a notice. They were supposed to be language about that coming out October 1st. To the best of my knowledge, that language is still not out, although I admit I did not check in the last 36 hours. That language is supposed to be starting to be used January 1st, but it'll be 90 days from whenever they get around to sending this language out. And, you know, we'll try to update you when that happens. It's certainly on Monitor Monday. Now, I want to spend a minute talking about the past, because I have been frustrated for a long time about advice I've heard lawyers give about past short stay guidance. And I want to highlight again the fact that you may get inconsistent advice from lawyers, and you need to push us to make sure we know what we're talking about. So when the 2 midnight rule came out, CMS said, you know, we used to have a 24-hour benchmark, and our proposed 2 midnight one is really just changing the 24 hours. They then said, we don't refer to level of care, right? And so the first interesting thing is people used to talk about the severity of the illness and the intensity of services. And there were all kinds of people who pushed really hard that ISSI test. That was never a Medicare test. It's in Interqual. It's in Milliman. Private insurers may use it. But at no point did Medicare use the severity of illness, intensity of service tests that every UR program in the country was using. So how did that come to be? Well, a bunch of consultants pushed it really hard. Let's look at what Medicare used to say. And I am doing this because I want to instill in everyone, as part of Healthcare 101, some cynicism, all right? Conventional wisdom is often wrong. Here's what the guidance said before October 1st, 2013. Generally, a patient is considered an inpatient if formally admitted as an inpatient with the expectation he or she will remain at least overnight. So let's pause for a moment here. It's 3 p.m. Someone comes into the emergency room. We know we're keeping them until the next morning. Are they an inpatient? And under that sentence, my answer would be yes, absolutely, all right? It goes on to say, even if they get discharged or transferred and don't use the hospital bed overnight. Now, let's skip the next sentence and go to the one in red. Physicians should use a 24-hour period as a benchmark, i.e., they should order admission for patients who are expected to need 24 hours of care. Now, let's think about those two sentences. Are they the same? Is overnight and 24 hours the same? Only in Alaska, north of the international date line, during the winter, right? Otherwise, that's different tests we've articulated. Third sentence. However, the decision to admit a patient is a complex medical judgment which can be made only after the physician has considered a number of factors. And then it goes on here with factors that are very difficult to figure out, like the availability of diagnostic tests. And you go, well, geez, which way does it cut, right? If they're available, that makes it better or worse. Why am I talking about this old guidance? A whole bunch of hospitals paid millions of dollars back on short stay cases back when that was the standard. And I'm sorry, you can't have a false claim back on this standard because there isn't one there. There is not a clear articulable standard. And I think a hospital could say if they expected the person to spend the night, that case was defensible. And I honestly do not understand why all kinds of lawyers said you got to settle this case, because I don't see how you make a false claims case in this context. And I'm also cynical of all of the people who sold utilization review on a criteria that aren't consistent with what was in the Medicare guidance. And I'm trying to instill cynicism and questioning the validity of what people are telling you. Okay, questions are pouring in. I've got just a few more slides left. We'll go through those, and then I will answer the questions. And we may go a few minutes over. It's the curse of having this many laws to cover. I just want to mention bundled billing principles really quick. This is more of a billing than law, but it's so important in the healthcare world. So within the DRGs are diagnostic-related groups. And hospitals now are traditionally paid either for inpatient services based on a diagnostic-related group, which is if you come in with, say, an MI, a heart attack, there's a code that goes with that, and there's an expected cost bundle, and the hospital gets that expected bundle regardless of how long you stay. And then there's APCs in the outpatient setting, where in the outpatient setting there's an ambulatory payment classification, sort of similar. Based on whatever diagnosis you've got, there's a fixed payment based on the anticipated services. Within the DRG world, there's something called the 72-hour rule, where diagnostic tests that are performed that are within the 72 hours in advance of your admission are bundled. And it's kind of weird because they don't even have to be related. If you get in a car accident and you break your arm and then you have an MI the next day, oddly, the car accident x-rays bundle if you're a Medicare person. Okay, so there's a whole bunch of stuff here. This could be a talk on its own on bundled programs. And I think in December we will be talking about the new, assuming the episode payment program is out sometime before, say, December 1st, we will be talking about that in our December webinar. Last thing I'm going to cover is kind of two related concepts, professional service arrangements and provider-based billing. So we're seeing a lot of this, the professional services arrangement where a clinic enters into a deal with the hospital where either the clinic or some component of its physicians contract with the hospital and the hospital's going to bill. And the reason that that's so common is that so far payment is higher for provider-based services. This could change, but currently you get better reimbursement for provider-based services. Now, there are some cons, and one of the cons people really don't think about. So people mostly do know that there's an additional copay if you're provider-based. People don't think about the loss of Incident 2. You can't use the Incident 2 benefit if you're hospital-based. You can do a shared visit, but that's it. Also, the 72-hour rule is going to apply, so diagnostic stuff is going to bundle. Now, I'm not going to spend a lot of time on this because three of my colleagues, Briar Andreessen, Katie Ilton, and Steve Beck, did a wonderful webinar in April of 2016, and you can watch it for free on provider-based stuff. So I will just do this really quickly, but I also want to mention, as they did, you can't do new off-campus provider-based departments. And so the provider-based world is broken into two pieces. There's on-campus, which is within 250 yards of a hospital, and off-campus, which is everything else. And you can't go creating new off-campus provider-based departments now. And the reason for that is Medicare doesn't like the fact that they pay more for this provider-based stuff, and all signs are it may get stomped out. So the provider-based rules are somewhat complicated. You need to have public awareness. People have to know that they're in hospital space. It has to be discrete space. Katie Ilton and I have worked on a couple of situations recently where the government has come in and tried to say that if you're sharing space, if there's space that is shared between a clinic and a hospital, that's not acceptable under the provider-based rules. And I think the government's position here is a bit tenuous, but you have to know it's out there. They're saying that space has to be discrete, 24/7, and they're saying because of the public awareness requirement, you can't have space that is in the morning clinic space and in the afternoon hospital space. If you're off campus, there are additional rules that apply. The hospital has to own the entire thing. There has to be provider control, administrative reporting, and the like. The hospital specifically has to employ and can't lease staff. Now, this is only true off campus. You can lease people on campus. When you set up one of these provider-based deals, and it's common, you can pay the doctors a percentage of their billings, or you can pay them off of RVUs or hourly. This model is a big deal, and I think this is just a quick overview. With this setup, you can watch that April webinar. All right, let's just start trying to whip through questions. First one here is already going to stump me. So have I heard of Blue Cross Blue Shield requiring a change in diagnosis to a medical diagnosis and not a psych diagnosis because it makes the case fall into a different DRG? And my answer is I have not. It's certainly possible. I'll tell you, we have had a lot of fights with Blue Cross Blue Shield is keeping us gainfully employed right now. Let's see. I got a bunch of split share incident 2. So let's just see how we do with these. And actually, before I read the questions, I'm just going to just mention we're not going to do a webinar in November. Our next one will be December 14th on a whole bundle of things, probably the new fee schedule rule, bundled payments, and the like. Okay, now trying to do these questions. Can I speak to the 2016 changes regarding writing requirements and contemporaneous documentation? And I honestly have to say, I'm not sure what 2016 changes this person is talking about. I don't know of any explicit, so okay, a challenge here, right? Are we talking about a Medicare requirement or some private payer? And who's sticking this one out? I don't know what requirement we're talking about here. I do not believe that there is an explicit requirement of contemporaneous documentation. If there is, I would encourage this person to send it to me because it's possible I've missed something, and it is always good to know the rules. So I don't know the answer to that one. I hope the person will shoot it to me. A split shared is a question because it would be difficult to understand a doctor would start a service and then the mid-level would be making all of the decisions but bill as the physician. If the MD doesn't indicate in the plan of care for the mid-level to treat everything related to the original service, this person would disagree with my statement. So if a doctor is seen by the MD for a lesion removal and then came in for a cold, it's a new problem, and according to CMS, this is a new problem and shouldn't be billed as incident 2. There's a lot going on in this one. So first off, in the shared context, which is in the hospital, it's very clear. If you've got a doctor and a non-physician practitioner who both provide face-to-face encounters, you can combine them, and it doesn't matter what order in which you see them. So I'm very comfortable with that. Now, I like it when people disagree with my statements. I always encourage them then to cite to the rule, right? Now, this question about a lesion removal then comes in for a cold. I think there's a fair question. Is the cold part of the course of treatment for a lesion removal? And I think a reasonable person could say, no, it's not. I don't think that's crazy, right? And one important thing to keep in mind is you have to decide risk management-wise what approach you want to take. You get advice from a lawyer. I may tell you what I could defend. You may choose to be more cautious, and that's not unreasonable. I'm going to tell you that if you're in an overpayment, I could make an argument that I can defend it. And if someone's coming at you for $1 million, I think you want to get the most aggressive defense you can get. But you may choose ahead of time to say, look, we're not going to get close to the line on this. We want, if the person comes in with a new problem, we're going to say that that can't be incident to. And that's fine. You can do that. I'm just trying to lay out the framework of what I would defend if necessary. Okay, Medicare requires that services provided and ordered be authenticated by the author of the document. Is it true that the billing and supervising physician must sign ancillary staff documentation when the billing and supervising provider is not the author? One of our nurses completes a treatment note, and once treatment has been administered to the patient, this document is created by the RN and is electronically signed by her. We had some claims denied after Palmetto requested records, and the denial said that the billing and supervisor didn't sign the documentation. This is a great question. So first, let me give you my risk management answer. Sign the documentation. Now, let me give you my fight answer. You don't need to sign the documentation. It is quite clear. I'm in a fraud case right now where a client just had a whole bunch of charts denied because they weren't signed. And we'll win this, I am quite confident, because Medicare says, well, hang on, let's slice it, right? Orders. Some orders can require signatures. And actually, we have a webinar on this too. Katie Elton and I did a webinar on orders. But medical record entries, there are conditions of participation that require they be signed in the hospital or in the ASC, but that isn't a condition of payment. Medicare says that if a note isn't signed, Medicare is supposed to ask for an authentication from the doctors after the fact. People should not be, and when I mean people, MACs, should not be denying charts because they're not signed, period. And you could and should appeal those. Now, this is an example. I would not tell people don't sign charts. I'd say sign charts, because if you don't sign them, you're going to get denials and you're going to have to hire me to do an appeal, and it's not worth it. It's easier to just sign the darn thing. But it is not a condition of payment, and if you found an unsigned chart, you should get the doctor to sign it. And actually, that highlights the silliness of this whole thing, right? Like, let's go back to the discussion about false claims, that something had to be material. A signature does not prove the doctor was there. The doctor could have signed it a week later, a month later, or a year later. There's nothing about the signature that proves squat. In the electronic world, where there's a time that goes with the signature, it perhaps proves a little more than it did in the old days. But you can tell you hit a nerve on that one. All right, next one. Some of these are somewhat complicated. Besides the obvious cost difference, what's the difference between providing a pizza lunch to get the doctors to listen to a sales rep and holding a training event in San Diego? A good question. And actually, to me, I think the cost difference is the most of it, right? Some of this comes down to, is anyone's judgment going to get influenced by a pizza? And I would say no, despite the fact that if it was a really good New York pizza, maybe, if it's a chocolate malt, mine personally would be. But it really is the cost difference that's mattering there. Tickets to a minor league baseball game aren't going to scare me in the way that tickets to the Super Bowl are. So it really is the cost difference that's, in my mind at least, making all the difference. And I guess the question there is, would a reasonable person's judgment be swayed by it? Regarding Stark's non-monetary compensation exception, can each hospital in a health system, each hospital has their own NPI, provide up to $392 to a physician, which is the current amount? I'm stumped. I would have to look at this one. I don't know the answer to that, if it's system-wide or hospital-wide. That one's too hard for me. We're happy to look at that one. I just can't answer that one off the top of my head. If the agreement expires, can a new agreement be created that goes back to the date of the previous agreement's expiration? So Stark now has some holdover provisions, but those are complicated and you have to get into those. So the easy answer is avoid them. But if you can't, then you do the best that you can do. For shared visits, do the providers have to be part of the same group practice? And I believe the answer to that is yes. I think that's, I got a couple of more here, but I think as I read through these, I am going to call it a day right there. I hope this is useful. You should get an email from us within a couple of days that will include a survey. We'd love to hear what you think of this. We'd also love to hear about other topics. We've got the next few charted out, but we like hearing about them. And if any of my colleagues or I can ever help you with anything, we'd certainly love to. I hope you'll join us in December, when really I think most of the whole group will go through a bunch of the new rules, and then in January as my colleagues talk about HIPAA. Thanks, and I hope that October the 13th is not unlucky for you.